This is Dr. Madhuri from Team MDSCONQUER. We'll see the glands of oral medicine and pathology subject in this video. So here the clinical pictures are given here. If you see, this is a retrognathia, glossoptosis, and because of this glossoptosis there is an airway obstruction. So these three features, if you combine, it comes under which syndrome? That is PeriRobin Syndrome. And you can also see here the patient of PeriRobin Syndrome will have a board-like faces, and this is because of retrognathia, and this is mainly because of the retrognathia. And if you take this patients of PeriRobin Syndrome will also have cleft palate. Okay, so the important features of PeriRobin Syndrome includes board face, retrognathia, airway obstruction, and the glossoptosis. So there is a PeriRobin sequence. Okay, we'll see the syndromes which comes under this PeriRobin sequence. PeriRobin sequence is nothing but a isolated clinical feature. That means the patient will have a glossoptosis or a cleft palate, or only cleft palate, or obstruction along with the cleft palate. So it is an isolated phenomenon. Okay, so this isolated phenomenon can be seen in other syndromes also, like Stickler syndrome, Willow-Cardiofacial syndrome, Tracheocolin syndrome, and fetal alcohol syndrome. Okay, remember PeriRobin sequence. Okay, see the terminology. Sequence is also seen in other syndromes like Stickler syndrome, Willow-Cardiofacial syndrome, Tracheocolin syndrome, and fetal alcohol syndrome. So the syndrome given here is a clinical feature of, if you see that clinical picture, so this is a picture of Tracheocolin syndrome. Okay, and the important point you have to note in Tracheocolin syndrome is fish face. Okay, bird-like face is PeriRobin syndrome, whereas fish-like face is the Tracheocolin syndrome. And one more important point you have to note here is coloboma. Okay, coloboma of eye also belongs to Tracheocolin syndrome. And in these patients will have a ear malformations. Okay, there is no complete absence of ear, or a partial development of complete absence of ear or a partial absence of ear, and only a one earlobe can also be seen. Okay, so coloboma and ear defects and the fish face belongs to Tracheocolin syndrome. And you have to remember the facial or a clinical appearance of these syndromes also, which they can be asked as a clinical based question or a picture based question. Coming here, this is the PeriRobin syndrome. If you see here, this face cut also relate with the scleroderma. Okay, there is a terminology called as NCOBD saber. Okay, which is mostly called as localized or linear scleroderma. Okay, so if they ask about a syndrome which is related to the linear scleroderma or a localized scleroderma, then your answer will be of your PeriRobin syndrome. Okay, so this is the facial appearance of a PeriRobin syndrome. Only important point here, that is it relates with the scleroderma, and the term which is related to both this is NCOBD saber. So we have seen board-like faces and fish-like faces. Now we'll see the frog-like face. Okay, frog-like face belongs to Krausen syndrome. Okay, Krausen syndrome is a craniosynostosis. Okay, remember the terminology. Craniosynostosis belongs to Krausen syndrome, and here the patient will have a frog-like face or a clover leaf skull on the radiograph. Okay, so three things here: craniosynostosis, frog face, and the clover leaf face belongs to Krausen syndrome. Then coming to the Melkersson-Rosenthal syndrome. So what are the features you can see here in this clinical pictures? One is the fissured tongue. Okay, so this is the fissured tongue. and you can see this cheilitis granulomatosa, and along with this you can see that cheilitis granulomatosa or swelling of the lips, and along with this palsy, unilateral palsy. Okay, so all these things belongs to Merkerson-Rosenthal syndrome. Only the important thing is fissure tongue. So the tongue appearance in the Merkerson-Rosenthal syndrome is fissure tongue. Okay, so identify this tongue picture, clinical picture. You can see here, this is called as hairy tongue, and in the hairy tongue you have to remember the filiform papillae. Okay, so in the hairy tongue the filiform papillae will be elongated or hypertrophied. So they can ask you regarding the papilla. Okay, so in the hairy tongue the filiform papilla will be elongated or hypertrophied. One more important tongue feature here, macroglossia. Okay, so everyone knows that macroglossia is in Beckwith-Widman syndrome. So there are other 3 syndromes given here along with this Beckwith-Widman syndrome, where you will see the macroglossia. The other 3 syndromes include Down syndrome, Turner syndrome, and Behmel syndrome. So you have to remember these 4 syndromes. Okay, so where do you see macroglossia? That is Beckwith-Widman syndrome, Down syndrome, Turner syndrome, and the Behmel syndrome. So in these 4 syndromes you can see the macroglossia. Okay, there are 2 types of teeth, that is natal teeth and the neonatal teeth. Okay, what are the natal teeth? Which are present at the birth. Okay, so the natal teeth are the teeth which are present at the birth. If you take the neonatal teeth, the teeth present in first month of birth, that is within 30 days, they are called as neonatal teeth. So in this slide they have given 3 type of disorders and or syndromes where we will see the natal or a neonatal tooth. They includes Riga-Fede disease, Hallermann-Streiff syndrome, and Ellis-Van Creveld syndrome. So in these 3 syndromes you can see the presence of natal teeth. See, this is a very important point. So in these 3 things you will see the presence of natal teeth, that is Riga-Fede disease, Hallermann-Streiff syndrome, and the Ellis-Van Creveld syndrome. Here the classification of cysts are given. So this classification is based on tissue of origin. Okay, so they can ask that cyst, which they can ask you in multiple option questions, like which are derived from the rest of malacis, that is periapical cyst and the residual cyst, and which cysts are derived from the reduced enamel epithelium, that is dentigerous cyst and the eruption cyst. And there are a few cysts which are derived from the dental lamina or rest of serous. So these cysts include odontogenic keratocyst, gingival cyst of newborn, gingival cyst of adult, lateral periodontal cyst, and the glandular odontogenic cyst. Okay, so remember these things which are derived from the rest of malacis, which are reduced enamel epithelium derivatives, and which are the derivatives of rest of serous. Coming to the fissural cyst. Okay, here I have given a list of cysts which are called as fissural cyst. Okay, we'll see them. So a median anterior maxillary or a nasopalatine cyst, median palatal cyst, globulomaxillary cyst, median mandibular cyst, and a nasoalveolar or a nasolabial cyst. So all these cysts are the fissural cyst. Okay, so remember these names: median anterior or maxillary, nasopalatine, median palatal, globulomaxillary, median mandibular, and nasoalveolar or nasolabial cyst belongs to the fissural cyst. So important definition regarding ameloblastoma. Okay, you can remember the short term like UNICEF. If you see, that is unicellular. This is according to the Robinson's classification of ameloblastoma. This definition was given. So it is a unicellular, it is a non-functional, it is intermittent in growth, it is clinically persistent and it is anatomically benign. Okay, so ameloblastoma, unicellular, non-functional, intermittent in growth, clinically persistent and anatomically benign. So you have to remember these 5 terminologies regarding the ameloblastoma, and which is according to Robinson classification. And histologically, actually there are 6 common varieties of ameloblastoma. So other than these 6 common varieties, there are also 3 rare varieties histologically. Okay, we'll see the common varieties. Common varieties includes the follicular, plexiform, acanthomatous, granular cell. In granular cells, you will see the lysosomes. Okay, then basal cell and desmoplastic. So this follicular, plexiform, acanthomatous, granular cell, basal cell and desmoplastic belong to the common histological varieties of ameloblastoma, whereas rare varieties includes clear cell, papilliferous and keratoameloblastoma. So please do remember these 3 histological varieties which are the rare varieties of ameloblastoma. Coming to the 2/3 tumor. So they can ask like which is a 2/3 tumor. So that is nothing but a adenomatoid odontogenic tumor. AOT is also called as 2/3 tumor. Why? Because 2 important reasons is 2/3 of this cases appears in anterior maxilla and 2/3 of the cases are associated with impacted canine. Okay, so because of these 2 important reasons, it is called as 2/3 tumor. That is 2/3 associated with anterior maxilla and 2/3 of cases are associated with the impacted canine. We'll see few features which are not seen in squamous odontogenic tumor. Okay, so as they have given like squamous, most of the students think they have features which are related to epithelial dysplasia. Okay, but I am giving a list of 4 very important features and they can ask you in statements. Okay, the 4 statements given, the 4 features given here are not a feature of squamous odontogenic tumor. Okay, so they can ask you like a true or false based questions. So squamous odontogenic tumor do not have pleomorphism, it doesn't have nuclear hyperchromatism, it doesn't have mitotic activity and it doesn't have the epithelial pearls. So remember, they do not have pleomorphism, they do not have the nuclear chromatism and they do not have the mitotic activity and they do not have the epithelial pearls. So remember, these 4 features are very important which are not seen in squamous odontogenic tumor. There are 3 features given, that is oral. A patient comes to you and he has a oral lichen planus plus hypertension plus diabetes mellitus. Okay, if you see these 3 triad, there is a diagnosis. There can be a diagnosis for this 3 triad. Okay, that diagnosis is nothing but a Greenspan syndrome. So the Greenspan syndrome triad will be of your oral lichen planus, hypertension and the diabetes mellitus. So identify this syndrome. This is syndrome or a disorder. It is nothing but a cleidocranial dysplasia. So the most characteristic feature is hypoplastic clavicles and they can bring their shoulders too closer. Okay, so hypoplastic clavicles, hypoclavicles, or even in few cases the clavicle is absent. Okay, so this is seen in cleidocranial dysplasia or dysostosis. And here the important gene is your CBFA1 gene. Remember, CBFA1 gene is associated with your cleidocranial dysplasia. So what here, this is a macule. Okay, so this is a feature of hereditary hemorrhagic telangiectasia. Okay, the what is that feature? This is a cherry red macule on the skin with a crushed spider appearance. Remember this statement, cherry red macule on the skin with a crushed spider appearance is a feature of hereditary hemorrhagic telangiectasia. You can see this is a red macule, cherry red macule. And one more thing is given here, that is a Herald Patch. Okay, where is the Herald Patch is a feature of Pityriasis rosea. Okay, in Pityriasis rosea you can see the Herald Patch. It is a very important feature. And this is also a red macule. Remember two things here. One, cherry red macules, crushed spiderweb appearance with is seen in hereditary hemorrhagic telangiectasia, whereas this red macule which appears in the form of a patch, that is nothing but Herald Patch, is seen in Pityriasis rosea. So what can you suspect in this patient? You can see in this patient there is a perioral pigmentation or a freckle type of appearance. Okay, perioral pigmentation or freckle type of appearance over the perioral region. So in these patients, what can you suspect? You can suspect a Peutz-Jeghers syndrome. Okay, in these patients you can suspect a Peutz-Jeghers syndrome. So if the patient comes with perioral pigmentation, you can directly, or you can advise the patient to take a endoscopy, because even this patient will have a polyposis, endoscopy of intestine. Okay, so the features important in Peutz-Jeghers syndrome are perioral pigmentation plus an intestinal polyposis. Okay, what is this lesion which mimics the carcinoma? So that is necrotizing cylometaplasia. It is a salivary gland disorder and it mostly mimics the mimics the squamous cell carcinoma. Okay, and this necrotizing cylometaplasia may develop more during even the palatal injections also, that is forceful or a traumatized or a pressurized palatal injections. It can cause the necrosis over the region, so loss of blood supply, and it results in the necrotizing cylometaplasia, which sometimes mimics the squamous cell carcinoma. And one more thing, there will be, you can also suspect a, you can see the deep DD, that is differential diagnosis for this palatal necrosis or perforation. Those are deep fungal infections. And one more important here is syphilis. Okay, so syphilis, deep fungal infections and necrotizing cylometaplasia can cause the necrosis of the palate, necrotic lesion of the palate. So what is the gold standard diagnosis for the Sjogren syndrome? That is lip biopsy. Lower lip biopsy is a gold standard diagnostic test for the Sjogren syndrome. Remember, this is a very important point, that is gold standard for the diagnostic test for the Sjogren syndrome is lip biopsy. Here a classification of candidiasis is given. So in this classification, the very important things are candida associated lesions. Okay, what are the candida associated lesions? They are Densest Stomatitis, angular cheilitis, median rhomboid glossitis. That is Densest Stomatitis, angular cheilitis and the median rhomboid glossitis are the candida associated lesions. There are two lesions here asked here. One is a kissing lesion and one is a kissing disease. Okay, what is the clinical picture given here? It is a kissing lesion. So in this clinical picture is nothing but a multifocal candidiasis is associated with kissing lesion. Why? Because the patient might develop a candidiasis on the tongue, and if the tongue touches the palate, on palate also the lesion may develop. So hence it is called as a kissing lesion. And there is a one more term called as a kissing disease. What is kissing disease? It is infectious mononucleosis. Okay, so kissing disease is an infectious mononucleosis caused by Epstein-Barr virus. So you have to remember, kissing lesion is candidiasis, whereas kissing disease is infectious mononucleosis, which is caused by Epstein-Barr virus. Coming to the densest stomatitis, there are three. This is a clinic picture based question. So here there are three types of candidiasis include on the densest stomatitis. So the first one is the patient will have a erythematous region only on few focal areas of the palate or the alveolar ridge. Okay. So if you take the type 2 densest stomatitis, the patient will have the erythematous region over the complete alveolar ridge. But if you take the type 3, the patient will have a erythematous region and also the granular type of lesions all over the palate. Okay, so the type 1 only focal, type 2 alveolar ridge, type 3 entire palate, and you can see the granular growths also. And one more important thing, that is snail track ulcer. If you see, this is a snail track type of ulcer where it is seen in the secondary syphilis. So don't confuse. If they ask about the snail track ulcer, it is seen in the secondary syphilis. One more thing, HPV 16. Okay, HPV 16 is more important because it is a high risk type of papilloma virus and most commonly involved in the carcinomas. So HPV 16 is a very important number because it is a high risk and also associated with most of the oral carcinomas. What is this? See, you have to concentrate on the clinical picture. That is, this is a oral hairy leukoplakia and caused by Epstein-Barr virus, and it also associated with HIV. So they can ask you, are they present in the form of a clinical picture? So concentrate on the clinical picture, which occurs mostly on the lateral border of the tongue, and it associated with the HIV and caused by the Epstein-Barr virus. It is oral hairy leukoplakia. So this is the classification of HIV infection. There are three groups, that is group 1, 2 and 3. Group 1 and 2 given here, the lesions which are strongly associated with the HIV infection, which includes candidiasis, hairy leukoplakia, Kaposi sarcoma, non-Hodgkin's lymphoma and periodontal diseases. So these are the lesions which are strongly associated with the HIV infection. But if you take the group 2, they are less commonly associated with the HIV infection. That includes bacterial infections, melanotic hyperpigmentation and necrotizing ulcerative stomatitis. Okay, group 2 less commonly, whereas group 1 lesions strongly associated with HIV infection. And here the lesions which are seen in HIV infection, that is bacterial infections, drug reactions, lichenoid reaction, epithelioid angiomatosis, fungal infections other than candidiasis, neurological disturbances and recurrent aphthous stomatitis. Okay, so all these things are lesions which are seen in HIV infection. So first one is strongly associated, second the group 2 is less commonly associated, and third will be seen in HIV infection. What is this? Alarm clock headache. Okay, alarm clock headache is seen in spinopalatine neuralgia. So alarm clock headache is seen in spinopalatine neuralgia. And due to which nerve damage, there is a paroxysmal crying during eating. Okay, so the paroxysmal crying during eating, it is due to the damage of facial nerve. This is very important. Because of this damage, there is a paroxysmal crying. Now this is a what sign and seen in which syndrome? So this is called as a Sternberg sign. Okay, remember Sternberg sign, and it is seen in Marfan syndrome, and this is also a clinical picture based question. That is, this is a Sternberg sign which is seen in Marfan syndrome. So this is a clinical based question, so you have to identify the syndrome based upon the facial features, and it is very easy. That is Down's syndrome. So this is a Down syndrome patient. And here even this patient is a Down's syndrome. Even this patient also has a Down's syndrome. So this is a direct question they can ask, to identify the syndrome. So based on the facial features, you have to identify the syndrome. And you can see here there is a frontal bossing. And in some patients there will be of a hypoplastic maxilla or mandible. Again, you have to mix these clinical features. That is, the more important thing you have to note here is the multiple oral papillomatous lesions. Okay, multiple oral papillomatous lesions, and you can see warts or the skin manifestations. Along with, the patient may complain of a uterine cancer or a breast cancer. So the multiple, one important is this, the multiple oral papillomas, and the patient may have a complaint of a breast cancer or a uterine cancer. Then your diagnosis will be Krausen syndrome. So they can ask you like this combination type of questions also, with which is only diagram based. Okay, so you have to know the each and every feature, at least the important features of syndromes. And what is this clinical picture? So lion-like faces, it is seen in Paget's disease. Okay, so initially we have read bird-like faces, fish-like faces, frog-like faces. Now the lion-like faces, it is seen in Paget's disease. So remember these faces. What is this appearance of the mucosa? You can see here, this is a cobblestone appearance. Okay, cobblestone appearance of mucosa. Where do you see this cobblestone appearance? One important thing is Crohn's disease. Okay, and the second more thing is Heggs disease. Okay, so in the Crohn's disease and the Heggs disease, and also in the Pyostomatitis vegetans. Okay, so Crohn's, Heggs disease and Pyostomatitis vegetans, you will see the cobblestone appearance of the overall mucosa. So remember these 3 points and also the picture. And based upon this, can you diagnose the syndrome? That is nothing but Frey syndrome. How can you diagnose this as a Frey syndrome? If you see here, the patient has a sweating over here, and that too the gustatory sweating that near the ear, and also you can see the flushing. Okay, so the flushing and the gustatory sweating is associated with the Frey syndrome. Okay, now we will diagnose few cases with their clinical features or clinical presentation. So here a patient, I have written only important points or hints for the diagnosis. Okay, the patient complains of a swelling in the floor of the mouth. This is the first point, and that swelling is since 6 months. And that patient has pain, and that pain increases while eating. Okay, and the fourth one, on palpation, it is tender and hard. Okay, the swelling in the floor of the mouth since 6 months, pain increases while eating, and palpation, it is tender and hard. Okay, so with all these things, if the floor of the mouth, so you can think of few lesions like a ranula or a lipoma or a cylolith. Okay, but okay, so you can remove these 2 lesions. Okay, why? Because on palpation it is tender and hard. Okay, whereas ranula and lipoma will be soft and non-tender. Mostly they will be soft and non-tender. Okay, so there is only one thing here, that is cylolith. Okay, relate to these points. Cylolith can be seen in the floor of the mouth, which is mostly because of that submandibular cylolith, and it can present since many days, like a chronic silidinitis, and the patient had presented with a So the patient has a swelling in the floor of the mouth, okay, since 6 months. So I have given only important hints for the diagnosis, okay. So the patient complains of a swelling in the floor of the mouth, that is first hint. Second will be it's a chronic lesion, that is since 6 months. Third is pain increases while eating, and the fourth thing is palpation, it is tender and hard, okay. So here the swelling in the floor of the mouth, what can you expect in the floor of the mouth? Usually regular cases, you can go for the ranula or a lipoma or a cylolith. So but in palpation I have given that is tender and hard, right? So you have to eliminate the options. Ranula and lipoma, these both are soft in consistency and non-tender. Mostly they are soft in consistency and non-tender. And if you take, the pain increases while eating, okay. See, cylolith is hard in consistency, and floor of the mouth, yes, it can present in the floor of the mouth because of that submandibular lesion, or if it involves the submandibular gland. And it can present from 6 months, yes, it can present from 6 months like a chronic cylodinitis. And one more important feature is pain increases while eating. So all these 4 features are related to your cylolith. So the patient has pain since 6 months, right? So it is in 6 months and the patient has pain while eating, increases while eating. So you can go for chronic cylodinitis. Maybe because patient is developing the bacterial infection because of this cylolithiasis, okay. So chronic cylodinitis secondary to cylolithiasis can be your provisional diagnosis. Next one, the patient has, it is a 22-year female, that is young female. Complaint, missing teeth. On examination, the patient has sparse hair, periorbital pigmentation, reduced salivation, and OPG, multiple missing teeth. Okay, the positive findings here are sparse hair and reduced salivation. So with these things along with missing teeth, you can go for your provisional diagnosis as ectodermal dysplasia, because the patient has the reduced salivation and decreased number of teeth and also the decreased number of hair, that is ectodermal structures are dysplastic here. So you can go with the provisional diagnosis ectodermal dysplasia. And here the case, the patient is a 40 years male and he has radiotherapy completed 15 days back. And in this patient, oral mucosa is ulcerative and very tender. Okay, in which cases you can see oral mucosa very ulcerous and tenders? Maybe you can see in infectious conditions, or you can see in autoimmune conditions like our erosive lichen planus or a pemphigus. So in these infectious conditions, or most commonly, or a autoimmune conditions, you can see the ulcerative or a tender oral mucosa. And even, but here there is a hint given, that is radiotherapy. So the patient had underwent radiotherapy. So in these type of patients, the patient can develop radiation mucositis. So you can eliminate these two and you can go with radiation mucositis with this positive finding, that is radiotherapy. So in the diagnosis, provisional diagnosis will be radiation mucositis.